All right, we'll go ahead and get started. Good afternoon, everyone. Today I will be reviewing the management of acute agitation. So before I begin, I would like to state that I have nothing to disclose prior to the presentation. And here are the objectives that I will cover today. So agitation is defined as a psychomotor disturbance characterized by a notable increase in both motor and psychological activities. It involves a loss of control of action and the disorganization of thought. Agitation includes an excessive release of dopamine, glutamate, acetylcholine, and norepinephrine, along with diminished levels of GABA and serotonin. The dysregulation of these specific neurotransmitters are important to know when determining drug therapy regimens for an agitated patient. So there's several etiologies of agitation. They can be disease-related, which includes traumas, things like burns and head injuries. It could be related to an infection like meningitis or encephalitis, or it could be related to a CNS disturbance like a stroke or a brain tumor, or the patient is in a post-ictal state after a seizure. It could also be related to a metabolic or endocrine disorder, such as hepatic encephalopathy or thyroid disorder. It could also be a toxicological cause, like an overdose or an intoxication of something like a stimulant. It could be due to alcohol or benzodiazepine withdrawal, and could also be related to adverse drug reactions like serotonin syndrome and steroid-induced psychosis, and could also even be related to drug interactions. So another cause of agitation could stem from psychiatric illnesses, such as patients with dementia, schizophrenia, bipolar disorder, and personality disorder. So these lists are not all inclusive, and it's important to consider that the agitation may be due to a combination of some of these things as well. So that brings us to our first test your knowledge question. Which of the following is a known etiology of agitation? If you answered D, that is the correct answer. So I'll first discuss the presentation and management of acute agitation in the emergency department. So behavioral emergencies in the ED can include things like acute psychotic disturbances, mania episodes, and substance abuse, including either intoxication or withdrawal. It can coexist with or be caused by a disease. And the main goals of therapy will include keeping the patient and the ED staff safe, ensuring that there's an appropriate initial assessment completed, and utilizing optimal treatment to adequately calm the patient so that he or she can be thoroughly assessed by a clinician. The first few things that will need to be done is the initial assessment of the patient, where the staff will evaluate things like vital signs, a neuro exam, a psych history, and they'll also get things like a tox screen and a blood alcohol level. So while evaluating the patient, it's also important to collect information from outside facilities, significant others, family members, and paramedics to try to get a better picture of what is going on and how the patient was behaving before they got to the ED. So after evaluating the patient and collecting that information, the staff should utilize a validated tool to measure agitation severity and the violence risk. Some examples include a behavioral activity rating scale and the positive and negative syndrome scale, the excited component. So we currently do not use a scoring scale in the Erlanger ED, but implementation of one of these scales could be beneficial for providers and pharmacists that are assisting in the care of these patients, especially when they're not initially involved or physically laying eyes on the patient. So the behavioral activity rating scale ranges from 1 being difficult to arouse to 7 being violently agitated, requiring restraints. The scale is easy to use and does not require the patient to participate and answer the questions. So the positive and negative syndrome scale excited component is more of a Likert scale with 5 scored sections, including excitement, hostility, tension, uncooperativeness, and poor impulse control. The total score is going to range from 5 being absent to 35 being extremely agitated. This scale is going to be more used in patients with a known psychiatric disorder like schizophrenia and bipolar disorder. So first-line therapy includes non-pharmacologic interventions. This includes things like verbal de-escalation, which is a combination of both verbal and nonverbal strategies intended to help the patient calm down and cooperate with their ED evaluation. Patients who are able to make eye contact and really engage in any form of conversation are going to be more likely to be de-escalated verbally. So on top of that, treating the specific underlying cause is really important. So for example, if the patient has a septic picture going on, make sure to get those fluids and antibiotics going. And if the patient is in immense pain, providing analgesia as soon as possible. Also, it's best to minimize physical restraint and seclusion if all possible. However, non-pharmacologic interventions will not always be successful, especially when the patient is severely agitated. Some indications for pharmacologic management include the patient failed the de-escalation techniques, the patient is a threat to themselves and or the ED staff, or the patient is showing extreme physical or vocal aggression. When pharmacologic therapy is indicated, you would like to treat the most likely etiology of the agitation, whether that be intoxication or withdrawal, the patient has a known psychiatric disorder, or maybe it's an undetermined cause or a complex presentation. So if the patient is intoxicated with alcohol or benzodiazepines, the first choice is going to be an antipsychotic, being either haloperidol or droperidol. A second line choice would include olanzapine. So in these intoxicated patients, you would not want to use a benzodiazepine as the very initial choice due to those additive CNS depressing effects. However, if midazolam or lorazepam can be used if the patient's severely agitated and the patient's needing an additional agent on board. So if that agitated patient is experiencing alcohol or benzodiazepine withdrawal, or is intoxicated with a stimulant, the first line choice is going to be a benzodiazepine, which could include things like lorazepam, oxazepam, or chlordiazepoxide. And then there's also phenobarbital, which is showing great benefit in patients with alcohol withdrawal. So if these agents are ineffective, you could use haloperidol or droperidol. And if the patient has taken an unknown substance, the first line choice would be a benzodiazepine, and the second line options would be haloperidol or droperidol. So it's important to realize that you can use a second line option either as an add-on to the first line options or as an alternative if the first line option is not effective after a few doses. Also, depending on the patient's level of agitation, it may be necessary to give them medications by the IM or IV route instead of the oral route. So at this moment, we currently don't have droperidol on the formulary at Erlanger. There was a period where it was difficult to get due to a prolonged shortage, and it is going to be more expensive than haloperidol. But as you know, things change and it could be added to the formulary in the future. So I did include it in this presentation for your information. So if the patient has a known psychiatric disorder and can safely take oral medications, the first line option is going to be olanzapine or quetiapine. However, quetiapine is going to take longer to work, so that should be kept in mind when making this recommendation. Some second line options would include haloperidol, droperidol, or another second generation antipsychotic, with an alternative option being a benzodiazepine. So if the patient cannot take an oral medication, IM or IV administration is going to be necessary. The first options are going to be olanzapine IM or ziprasidone IM. And it should be known that these drugs are going to require reconstitution prior to administration, and then they cannot be given by the IV administration. The second line options are haloperidol or droperidol, with the alternative option being a benzodiazepine. So just this year, there was a randomized controlled trial published that assessed patients with mild to moderate agitation that was associated with bipolar disorder. The intervention studied was sublingual dexmedetomidine, and the two doses analyzed were 180 micrograms and 120 micrograms. The authors found that 2 hours after the study drug was administered, there was a significant mean change from baseline in the PANSS PEC score. The treatment drug showed an effect in 20 minutes after it was administered, and the most common side effects were drowsiness, dry mouth, hypotension, and dizziness. So future research is needed to understand the spectrum of patients for whom this treatment would be effective, and to get a better understanding of the clinical importance of the observed effect that they saw in this study. But this is an exciting new look at an innovative formulation of dexmedetomidine in these agitated patients. So when a patient has an undifferentiated presentation, the first line option is olanzapine or another second generation antipsychotic. The second line options would be haloperidol, droperidol, or a benzodiazepine. So when the patient is elderly and experiencing delirium, haloperidol or droperidol would be the first options, and the second options would be olanzapine or a different second-generation antipsychotic. So it's important to remember to avoid benzos in these patients since it will worsen the delirium. Also, elderly patients may require lower doses due to their slower metabolism of medications. If the patient is experiencing acute violent psychosis, the first-line option is ketamine, which has shown great benefit in aggressive and combative patients in the ED. The second-line options would be either a first or second-generation antipsychotic or a benzodiazepine. And in these patients, they're probably going to require more than one agent, and they're going to require IM administration in most cases. So we'll start with talking about ketamine. It's a rapid-acting general anesthetic that produces a cataleptic-like state. It's an NMDA receptor antagonist in the central nervous system, and it's available in 2 formulations. The IM formulation is dosed at 2 to 5 milligrams per kilogram with a maximum of 500 milligrams. And the IV formulation is dosed at 0.5 to 1 milligram per kilogram, and it's given over about a minute. So the IV formulation is going to have a quicker onset, but a shorter duration compared to the IM formulation. Ketamine does have some adverse effects associated with its use, including an increase in blood pressure and heart rate. So it may not be the best agent in a patient with serious cardiac dysfunction. It also can cause hypersalivation, laryngospasm, and there's also the risk of emergence phenomenon, which is characterized by an increase in euphoria, illusions, and/or hallucinations. And it also can cause an increase in muscle function, which could be characterized by hyperactivity, twitching, and rigidity. So there's also some warnings associated with ketamine, including the rapid IV administration may increase the risk of respiratory depression and/or apnea. And if the 100 milligram per mil formulation is available, it really should be reserved for IM administration due to its highly concentrated nature. And ketamine should be avoided in patients with a known psychiatric disorder like patients with schizophrenia. So in a study assessing adult patients in the ED with combative agitation, patients received IM or IV ketamine and were compared to patients receiving haloperidol IV or IM in addition to Lorazepam IV or IM. So this study found that significantly more patients who received ketamine were sedated within 5 to 15 minutes. There was also a significant benefit in the median time to adequate sedation in patients who received ketamine. The patients who received the study drug did experience a higher rate of transient side effects, with tachycardia and hypertension being the most common. Overall, ketamine was significantly more effective than the haloperidol and Lorazepam combination for the initial control of these combative agitated patients. So this brings us to our next drug class, the benzodiazepines. They are GABA agonists, and they provide their therapeutic effect by decreasing anxiety. There's less benefit of their use in patients with psychiatric symptoms. So they're not going to be the drug of choice in those patients with a known psychiatric illness, but they can still be used as an add-on therapy. The side effects associated with benzodiazepines are hypotension, excessive sedation, respiratory depression, and retrograde amnesia. So in comparing Lorazepam and midazolam, I would like to point out that the PO, IV, and IM Lorazepam doses will all be 1 to 2 milligrams, but you can use up to 4 milligrams with a severely agitated patient. The IV or the IM and the PO formulation are going to have a slower onset than IV, and the duration of PO will be longer than that of the IV and IM form. With midazolam, the dosing will change based on the formulation that's used. IV and intranasal administration will have a quicker onset than IM. However, the effects of IM administration can be seen in just 5 minutes. The duration of these agents are going to be far less than that of Lorazepam, and this can be beneficial when you need to evaluate the patient after they've calmed down for an hour or two. And intranasal administration can have a benefit in patients that are severely agitated and that are difficult to keep still for an IM injection. The intranasal form comes as 5 milligrams per spray. So 5 to 10 milligrams would be 1 to 2 sprays. In this study, authors wanted to wanted to determine if IM midazolam was superior to IM lorazepam or IM haloperidol in the management of violent and severely agitated patients in the ED. They found that midazolam had a significantly shorter time to sedation and a more rapid time to arousal than the other two agents. They also found no significant differences in changes in blood pressure, heart rate, respiratory rate, and oxygen desaturation between the agents. Therefore, midazolam was the most effective of all these agents in the treatment of severely agitated and violent patients in the ED. So now I'll discuss the antipsychotic drug class, starting with the first generation antipsychotics. They work by antagonizing the dopamine receptors in the central nervous system. Some notable side effects of this drug class include extrapyramidal symptoms like dystonia, akathisia, and Parkinson-like effects, and they also carry the risk of QTc prolongation. The two agents have their own black box warning. With haloperidol, there is an increased risk of mortality in elderly patients with dementia-related psychosis, and with droperidol, there is the potential for arrhythmias. When comparing haloperidol and droperidol, the dosing of both agents are similar. When using haloperidol, you can reevaluate and repeat the IV or IM dose every 15 minutes until acute symptoms are controlled, with a maximum of 30 milligrams per day. With droperidol, you can repeat the IV dose every 5 minutes until adequate sedation is achieved, but it's advised to wait at least 10 to 30 minutes before providing an additional IM dose, with a maximum daily dose of 20 milligrams per day. The onset of haloperidol is going to be slower with the PO and IM formulation, but the IV formulation can show an effect in about 3 minutes. Droperidol has a quicker onset at about 3 to 10 minutes. The duration of haloperidol varies, but could last up to 24 hours with the IV form. And the duration of droperidol is roughly 2 to 4 hours, so could provide a quicker time to arousal if used. Some things to consider with haloperidol would be a higher risk of EPS. Some clinicians even consider administering it with a benzodiazepine to reduce this effect. And there's a higher risk of QTc prolongation if using the IV administration instead of the PO. While the IV formulation is not FDA approved, it is widely used. Things to consider with droperidol would be the increased risk of hypotension with the IV administration. In a study analyzing psychiatric patients with a behavioral disturbance of any etiology requiring chemical sedation, the authors compared patients receiving droperidol and haloperidol, both dosed at 10 milligrams IM. They found no significant difference in the median time to sedation between the two groups. However, additional sedation was used more often with haloperidol, but adverse effects were less common with haloperidol use. They concluded that both haloperidol and droperidol were effective for sedation in these patients. So an observational study was done to further investigate the safety and efficacy of droperidol for sedation of acute behavioral disturbances in the ED. 10 milligrams of IV droperidol was given initially, and if the patient was not sedated within 15 minutes, an additional 10 milligrams was given with a max daily dose of 20 milligrams. So about 1,000 patients got an EKG completed within 2 hours of droperidol administration, and only 13 patients had an abnormal QTc, which was defined using a QTc nomogram that accounted for heart rate and QT interval. Of those 13 patients, 7 of them were also taking other medications that could have also contributed to the prolonged QT. And those drugs include things like methadone, escitalopram, and amiodarone. The median time to sedation with droperidol was 20 minutes, and 31% of patients did require additional sedating agents. 5% of patients had a reported adverse effect, and 8% of patients were oversedated, but without any complications. Thus, droperidol use was proven safe and effective, with very few patients demonstrating QTc prolongation, with its acute use at a maximum dose of 20 milligrams. This brings us to our next drug class, the second generation antipsychotics. These medications work by blocking dopamine, serotonin, alpha-adrenergic receptors, and histamine receptors. And compared to the first generation antipsychotics, this drug class has a lower potential for EPS. However, the risk of QTC prolongation still remains a concern. And all of these agents are going to carry a black box warning for increased mortality in elderly patients with dementia-related psychosis. When looking at the different medications in this class, olanzapine has the same dosing for each formulation. It can be repeated every 2 hours if needed, with a max dose of 20 milligrams per day with the oral form and 30 milligrams per day with the IM form. Risperidone's oral formulation includes a tablet, a solution, and an ODT form, but this is the only route that's approved for acute agitation, and doses can be repeated every 2 hours if needed, with a max daily dose of 6 milligrams. Ziprasidone can be given as an IM injection at 10 milligrams, repeated every 2 hours as needed, or 20 milligrams repeated every 4 hours as needed, with a max daily dose of 40 milligrams per day with the IM form. And then oral therapy should replace IM administration as soon as possible. It's usually dosed at 20 to 40 milligrams once or twice daily, with a max daily dose of 80 milligrams per day. So it's going to take much longer for the oral form to reach a peak effect. Thus, this is going to be more of an option in those patients that are going to require something scheduled, such as a patient with a psychiatric disorder. Both olanzapine and ziprasidone IM have an onset as early as 15 minutes, but it really can vary for each patient. Olanzapine has an ODT formulation that can show an effect faster than any other oral antipsychotic. And like I said, risperidone is going to take the longest to be effective of all the agents in this class. Olanzapine and risperidone will have a longer duration than that of ziprasidone. And some considerations with each of these would include olanzapine's PO and ODT formulation are going to be bioequivalent. Risperidone has a high risk of EPS, but a lower risk of oversedation and hypotension with its use. And then ziprasidone is going to have the highest risk of QT prolongation of all the drugs in this class, and that is going to be dose dependent. Thus, it should be avoided in patients with a known history of cardiac dysfunction. And both olanzapine and ziprasidone don't have any clear evidence of the safety with its IV use and will require reconstitution prior to administration. So when comparing quetiapine and aripiprazole to the agents on the previous slide, they will have a much slower onset of action, and only the oral forms are available or approved for acute agitation management. They're not going to be the optimal agents in an agitated patient needing a fast-acting medication right away. So quetiapine is dosed at 25 to 50 milligrams initially, with a max dose of 400 milligrams per day. It's not going to be commonly used in the EDs due to its slower onset of action, but it is going to be very commonly used in the ICU and in floor patients to treat agitation. It's usually dosed twice daily or can also be dosed 3 times a day, possibly with a higher dose at night to help improve the sleep cycle in an agitated and delirious patient. Aripiprazole is dosed at 10 to 20 milligrams per day, with 20 milligrams being the max daily dose. This medication can last much longer than the other agents in this drug class. So this agent is going to be more commonly used as maintenance therapy in those patients with psychiatric disorders. And it does have little to no EPS, which is beneficial to those that are needing to take this medication for a longer period of time. So QTC prolongation is a risk with all of the antipsychotics, but it's important to know which has the highest risk and which agent has the lowest risk, especially when you have a patient that already has a high QTC at baseline. Ziprasidone and quetiapine are going to have a higher risk, and aripiprazole and olanzapine will have the least amount of risk associated with their use. So in a study analyzing patients in the ED that required IM agitation medications, the author compared haloperidol, olanzapine, midazolam, and ziprasidone. They found that at 15 minutes, midazolam resulted in a greater proportion of patients that were adequately sedated, defined as less than 1 on the altered mental status scale. And olanzapine resulted in a greater proportion of patients adequately sedated when compared to the other antipsychotics in the group. Adverse effects were uncommon and occurred at a similar rate in between each group. In a study that was published this year in patients with acute agitation in the ED, the author compared the use of the well-known and historically used combination of B52 which includes diphenhydramine 50 milligrams, haloperidol 5 milligrams, and lorazepam 2 milligrams, with another commonly used combination of haloperidol 5 milligrams and lorazepam 2 milligrams, which they called the 52. They found that there was no difference in the administration frequency of additional agents within 2 hours of giving the B52 or the 52. But they did find that patients in the 52 group had a shorter length of stay, a lower incidence of hypotension, no oxygen desaturation episodes, and fewer patients requiring restraints compared to those patients in the B52 group. Thus, it's recommended to probably leave the diphenhydramine out of the combination. So this brings us to our second test your knowledge question. Which of the following is the preferred agent in an acutely agitated patient intoxicated with methamphetamine in the ED? You said A, that is the correct answer. So now we will switch gears and talk about the presentation of agitation in the ICU. I'll focus on hyperactive delirium since these are the patients that are going to be agitated and requiring treatment. Agitation in response to hyperactive delirium is fairly common, occurring in about 40 to 50% of patients in the ICU, and it occurs very commonly in older patients. It may be caused by numerous factors linked to both the disease itself, including things like septic encephalopathy or CNS disturbance, and also to external factors such as pain, discomfort, noise, loss of body control, and poor sleep hygiene. So typically this cognitive alteration will vary throughout the day, and it commonly reaches its peak intensity during the night. It has been proven to worsen patient outcomes by threatening patient safety, increasing their length of stay in the ICU and in the hospital, and overall increasing patients' cost of care. When assessing ICU patients, it's important to identify the patient's pre-existing mental status, since roughly 30 to 40% of patients present to the ICU with some degree of cognitive impairment prior to their ICU admission. The clinician needs to know about their pre-existing mental status in order to establish whether a link exists between the presently observed condition and the disease that resulted in their ICU admission. Patients should be assessed at least once a day with a validated scale, such as the Richmond Agitation Sedation Scale, the Sedation Agitation Scale, to fully assess for their level of agitation, and then using the confusion assessment method for the ICU to assess for the presence of delirium. These methods can be used by ICU nurses at the bedside without being too time-consuming and adding too much to their daily routine. PADIS guidelines recommend a multi-component approach that includes a focus on non-pharmacologic approaches, which involves things like reducing modifiable risk factors for delirium and improving cognition and optimizing sleep, mobility, hearing, and vision in these critically ill patients. So here are some examples of some of the non-pharmacologic interventions that nurses and other people in the ICU complete on a daily basis. So they are going to be providing constant reorientation and cognitive simulation to their patients, providing adequate pain control, optimizing their hearing and vision, encouraging early participation in physical therapy, and improving wakefulness during the day while optimizing their sleep cycle at night. If non-pharmacologic interventions are unsuccessful and the patient does develop hyperactive delirium that results in agitation, the guidelines do provide some guidance on the management. So first things first, avoiding benzodiazepines since they've been proven to worsen delirium. An exception to this would be a patient that's on chronic benzodiazepines outpatient, however, the home dose could still be decreased. Guidelines do not support the use of antipsychotics for prophylaxis or treatment. Studies have shown no benefit with the use of antipsychotics in the prevention of delirium. However, they can be considered for short-term use for treatment. In a randomized control trial with a small number of patients, Quetiapine did show a benefit for patients within the treatment of delirium. And in the ICU at Erlanger, Quetiapine is commonly used as treatment in patients that are requiring medication management, but it should be weaned off once the patient no longer requires it and their mentation is beginning to improve. Other management strategies include Dexmedetomidine. Studies have shown benefit of its use in both intubated and non-intubated patients. Ketamine is another option, showing benefit with either a one-time dose or as a continuous infusion in intubated patients. And then valproic acid could be considered in patients with refractory delirium and agitation that aren't having an adequate response to the previously mentioned agents. So dexmedetomidine is an alpha-2 agonist with anesthetic and sedative properties, which results in the inhibition of norepinephrine release. It's a continuous titratable infusion. And at Erlanger, we use a dosing range of 0.2 to 1 microgram per kilogram per hour, but dosing ranges can vary based on the institution that you're at. It takes about an hour for a peak effect and can be titrated up every 30 minutes to a target RASS goal based on provider preference. Some notable adverse effects include a decrease in blood pressure and heart rate and a risk of respiratory depression with its use. In this study, adult patients in whom extubation was considered inappropriate due to severe agitation and delirium were assessed on dexmedetomidine starting at a rate of 0.5 micrograms per kilogram per hour, and then titrating up to 1.5 micrograms per kilogram per hour every 30 minutes as needed to achieve a light sedation goal. The authors found that the study drug significantly increased ventilator-free hours at 7 days. They also found that the use of the study drug reduced the time to extubation and accelerated the resolution of the delirium in ICU patients. Another option for patients when drugs like dexmedetomidine, ketamine, and antipsychotics have not been as effective is valproic acid. It mimics the GABA action and it is dosed at 250 to 500 milligrams every 8 to 12 hours when it's used for this indication. Some adverse effects associated with it include tremor, decreased platelet counts, hepatotoxicity, and elevated ammonia levels. In a study analyzing the use of valproic acid for the treatment of agitation and delirium, all patients started at a daily dose of 500 milligrams and titrated up as needed. However, most patients did not exceed 1,000 milligrams by day 7 of therapy as a total daily dose. The results showed a downward trend in both agitation and delirium by day 7 of therapy. And they also found that the addition of valproic acid reduced sedative, opioid, and antipsychotic requirements. No adverse effects associated with valproic acid were reported. Thus, valproic acid may be an alternative option to assist in the management of agitation and delirium in the ICU. So I'll conclude this section with a test your knowledge question. What is the main cause of agitation in ICU patients? If you said C, that is the correct answer. And to finish up, I will discuss agitation management in non-ICU patients. So delirium remains an issue even in non-ICU patients. And the thing with non-ICU patients is there's not a provider and residents hanging out close by in the unit like they do in the ICU. Roughly 30 to 60% of floor patients, with the majority being older adults, will experience delirium while staying in the general hospital ward. The longer the patient remains inpatient, the higher the risk of developing delirium. Another common issue in floor patients is sundowning. Patients that are sundowning develop restlessness, agitation, irritability, and confusion that begins and worsens as the daylight begins to fade away. Sundowning is a very common occurrence, especially in patients after surgery, those that are recovering from an acute illness or infection, or those patients that already have a pre-existing cognitive impairment. Other possible causes of sundowning include the lack of proper sleep that patients are getting in the hospital, and then unmet needs such as hunger or thirst, and then also things like depression, boredom, and pain. So in order to ensure a proper assessment is completed at least once daily in these patients, it is recommended that nurses utilize a scale such as the confusion assessment method, the delirium observation screening scale, and the delirium rating scale. So we currently do not have a delirium monitoring scale used on the floor at Erlanger. However, it could be beneficial for providers to know what patients are demonstrating clinical signs of delirium and that should be monitored more regularly. So the management of agitation in these patients will continue along that same route of focusing on non-pharmacologic interventions first, and then reorienting the patient as much as possible, along with treating the underlying cause of the agitation. When necessary, pharmacologic agents can be added to treat that agitation. They will include things like antipsychotics, which includes both the first and second generation antipsychotics, and the most common agent at Erlanger is going to be quetiapine. Benzodiazepines are going to be a drug of choice if the agitation is related to withdrawal, but it should be avoided if the patient is experiencing delirium. If the patient doesn't have any delirium, benzodiazepines can be used as rescue agents when necessary, but scheduled benzodiazepines really should be avoided in all patients. So while the majority of studies of agitated patients include patients in the ED and ICU setting, to some extent, that data can be extrapolated to a non-ICU patient, but with some exceptions in medication choice. For example, patients on the floor cannot receive ketamine and dexmedetomidine infusions. There's a few studies that do support the use of quetiapine in the treatment of non-ICU patients with delirium. In 2007, there was an open label study investigating the use of quetiapine in a small population of non-ICU patients, and they found that 88.2% of patients had a 50% or more reduction in their delirium rating scale, and the most common side effect they saw was daytime sedation. In 2010, there was a randomized control trial of just 42 non-ICU patients with delirium, and they found that delirium improved 82.7% more rapidly in those patients that were on quetiapine. Therefore, quetiapine does have some supporting evidence for delirium resolution in this patient population. But the same rules apply. Once the patient is improving or getting ready for discharge, this medication should be weaned off and discontinued when possible to avoid inappropriate long-term use. So in conclusion, when choosing between agents, it's important to keep things in mind like what drugs will require reconstitution and their diluent compatibility, the differences in the timing of onset of the different formulations, adverse drug effects and drug interactions, and potential factors like comorbid conditions like patients with a known psychiatric disorder or a patient that's actively withdrawing. Also, if you have the information, knowing if a drug has been proven effective for a patient in the past can be very beneficial in that moment as well. When making recommendations for an agitated patient, non-pharmacologic interventions are going to be the first thing you try. And then reorient the patient and provide verbal de-escalation techniques. If pharmacologic treatment is necessary, treat for the shortest duration that's possible. Calm the patient down, but don't over-sedate them. And de-escalate therapy when mentation and their behavior starts to improve. Many of the medication choices are going to be based on hospital and provider preferences. However, pharmacists can provide some guidance based on the patient information that they have, the setting that the patient is in, and the etiology of the agitation. Does anyone have any questions?
System that you talked about for ED use, you said we don't use a system in the ED currently. Do you think we should start using one, or is there a scale that we use that could be maybe substituted?
I honestly think her question was, she doesn't think, or we don't use a scale currently in the ED, and do I think that we should use one or use a different scale to substitute that? So I think that we already have built into Epic the RAS scale. So I think that that would be something that we could utilize also in the ED without really having any changes in Epic. So I definitely think that that would be something beneficial. It would just probably have to involve some nursing education and things like that, but I'm sure they already kind of do it anyways. So just writing it down wouldn't be too much extra effort on their part. Yeah, it was.
So they should be trained on the RAS already.
Mm-hmm. Yeah, exactly.
So I don't know if it's necessarily validated in the ED
Mm-hmm.
population, but
Yeah.
it looked pretty darn similar to that.
Yeah, and then that way when they go to the ICU, the people in the ICU already can easily read that. I agree. Lauren, did you have?
I wanted to ask about the sublingual trial that you talked about. Like when they gave it sublingual, were they just like an IV that's out of the vial and giving it, or did they have some?
I think it was actually a sublingual formulation. I can look back to that. I don't think that they were pulling it out of the vial though and doing it kind of like they do in like Robenol or something like that. I don't think it was like that, but I can look into it and I can even send you the study as well. What was that, Brady?
So when you talk about the risks of associated increased mortality with use of antipsychotics in elderly patients, what is the basis of that, and how should we educate providers when we have an agitated elderly patient maybe who has a history of dementia? How should we guide them to choosing those?
So her question was that black box warning that's associated with several of the antipsychotics where there's that increased mortality when used in patients with dementia-related psychosis, and how you would talk to a provider about that. So essentially, I think that's a difficult thing to overcome because those patients do require medications, and if those all carry that black box warning, I would essentially tell them that it is something that you could monitor, and I would use as small of doses as possible and try not to make it a scheduled medication, but it would be more of a patient-specific manner each time and just require a lot of monitoring because even with my research project, patients are still getting the medications. And there hasn't been any really increase in mortality parallel to that. But I do think that might have just been a historically, placed black box warning with it. It would just require additional monitoring in those patients. Yes, I think it would be appropriate at least, mine was on acute management. So I think it would definitely be appropriate in that regard. Yeah. All right. Well, thank you everyone for listening. Hope you all have a great rest of your day.